Good afternoon, everybody. Welcome to today's iteration of our Digital Health 10-year webinar series. This one is focused on digital foundations for neighbourhood care. I'm pleased again to be joined by a mixed panel from across the multidisciplinary teams that we represent across the networks and support across kind of digital health. I'll let them introduce themselves shortly. Just a quick intro. John, unfortunately, has to disappear for a fairly kind of urgent meeting, so won't be able to stay throughout. So I will utilise John as much as we can in the interim period. And also, just in terms of the format, we do record this. So if anybody needs to kind of backtrack, have a look at it, it will be posted up on Digital Health Post. There are no presentations as such, so we don't need to share any slides. The Q&A function doesn't work for this format, so if you do have any questions, please put them in the chat. I can have a look at those, and if there's some pertinent questions or burning issues that haven't been raised by the panel at that point, I will put those questions to the panel who can give their views on it. The idea is that we will try and talk about some of the generic policy and what that might look like, but also kind of local action, what's been done to date, what some of the priorities are, looking at some of the various different components of what neighbourhood and community care looks like, both from a technical, a clinical, policy and delivery point of view. I always forget to introduce myself. I am Carl Grundy. I'm the MD of Digital Health, but I'm not the most important person here. So on that note, I will pass over to Leah to introduce herself. Thank you, Leah.
Thanks, Carl. Thank you very much for inviting me to be involved. I'm Leah Alley. I am a doctor. I'm a consultant psychiatrist at the South London and Maudsley NHS Trust, and I am also on the CCIO advisory panel for the Digital Health Networks.
Yeah, and also just an absolute guru of user-centered design, which I'm shocked you haven't mentioned, Leah. John, could I come to you, please?
Of course. Hi, everyone. My name is John Mitchell, and I'm the Associate Director of Digital for Humber North Yorkshire ICB, and I'm also the Chair of the Digital Health ICS Digital Council. Thank you.
Thank you, John. Emma?
Good afternoon, everyone, and thanks for having me here. Emma McLaughlin, Director working across our national digital product and platforms capabilities in NHS England. So that's everything from the NHS app through to our vaccine services, referrals, appointments, and through to things like the NHS Spine. So good to see you. Thanks.
Thank you, Emma. Thank you, John and Leah. So I'm going to crack on with the first part of Neighbourhoods, which is digital foundations. Now, although this is called the 10-year webinar series, the guidance and guidelines for neighbourhood working, neighbourhood care, neighbourhood services was published actually before the 10-year plan. Part of that were some key components of focus from population health to multidisciplinary teams. But what underpins that are some of the digital foundations to make sure that people are able to communicate, whether they're against those core components or for future working in terms of future proofing some of that technology. So, John, I'd like to come to you first. If you could just give a bit of an overview of some of the digital foundations and the issues and differences that there's been between working across ICSs, local government, social care, etc. And then we can move on from there. Thank you, John.
Okay, thank you. So I think one of the things we're all going to have to battle with over the next few months is that neighbourhoods may have a different perspective on what they are, depending on where you are in the country. Okay, so if you have a look at some of the makeup of our organisations and our places as it currently stands, there are significant differences. So, from my own patch, if you look at somewhere like North East Lincolnshire, which is one of the pilots, you're kind of talking around a certain demographic. You're also looking at a certain makeup of providers. So, a KIC-oriented providers where we have KICs who offers trust-like services. Where if you compare to somewhere like York, where you've got a much smaller number of different types of providers involved in neighbourhoods, that actually you kind of need to take the basic principles and work out how we can make those work through digital enablers. So I'm saying this, Carl, one of the first challenge might be there is not one size fits all. Okay, which we're going to have to get our heads around. Secondly, we've been asked to do some things, I guess, in anger for the first times. So, yeah, how do you make sure that social care are equitable partners as part of neighbourhoods? How do you make sure that the voluntary sector are equitable partners during neighbourhoods? And then who's responsible for pulling all these things together? Is it kind of, our PCNs going to take the lead, of federations, our trusts? And again, that might be a different answer in each location, and then work out how we start joining those dots. Until we understand the makeup in each of our places, we know the core principles, but how do we then start to enable those digital tools so that people can start sharing the information where it's needed, where we can start to have a single point of truth where it's needed, so we stop duplicating information, making version control quite difficult. So single point of truth across varying elements of population and variance in providers is going to keep us all busy for a while, up until we get the next set of guidance next year. I think we're expecting a model neighbourhood framework sometime during 26-27. So we can start to put some of those building blocks in place. We can then start moving towards the next framework and see what changes and the neighbours we need. And we also then need to be conscious that there is a promised centrally provided community-based tool, which it will be provided by NHS England, and we just need to understand how then that will fit into the mix as well. So there's plenty to be going at, Carl, right now.
John, and I think you probably made it slightly less complicated than it actually is. But Emma, I'm going to come to you on this, and I think as part of this, one of the guidelines talks about a single system approach to population health management, or population health as a wider side. How is that going to happen? It's a difficult question, I know, Emma.
A single system approach to population health management. Well, thank you. I think I would refer back to John's points. I think ultimately what we're looking for here is actually a system-led approach, and we know that the systems are all at different starting points of maturity and the ability to look at population health. And I think our role nationally is to figure out what are the component parts of our enablers can do to support the different states of maturity for systems. So on that particular point, thinking about population health, one of the questions we've been considering is how we can support the different systems with case finding. And for example, we know some systems may have be involved in the FDP pilots. Some systems may have health and social care well joined up. Some systems may have their local SDEs. Some systems may have none of those things. But I think our role nationally is to figure out how we can best support the system at large, understanding the different levels of maturity to drive that outcome.
Yeah, Emma. So I'm taking this approach there. Obviously, a lot of people would argue that it needs to be led clinically rather than through digital transitions or necessarily kind of services. As the local record might be seen to be owned by the GP rather than the acute or the local mental health trust or social care or local government, how do you see this working as a clinical-led neighbourhood environment to get some of the outcomes we're trying to achieve here?
So I think one of the key things is starting from what the model is that we're trying to achieve and articulating that quite clearly, and also the fact that we're trying to transition. So essentially, a neighbourhood model is, people have heard me talk about this before, a biopsychosocial model. It means you are thinking about the person in the full context of their experience. And that's not like a little woolly nice to have thing. We have excellent evidence across multiple forms of integrated care, shared care, digital and non-digital industry, frontline NHS models that certainly I've been involved with, that the evidence base is that when you do that successfully, you improve health outcomes across all long-term conditions, and you also optimise system key performance indicators, attendance at A&E, attendance at GP appointments, outpatient appointments, etc. So you have to start from that clear place. At the moment, that's not what we have. What we have is a predominantly medicalised model. That's why traditionally the connections to social care and the voluntary sector are so poor. It doesn't come from the digital component, it comes from the existing actual face-to-face services and where our mindsets are in how we think about a person's experience. So once you start from that position, you know that's the job that we are actually doing to transition that. It actually starts to become easier because you're not starting from that technology-led bit of where the records sit, who owns it. You're starting from the patient and you're starting from the model and the outcome that you want to achieve. And then what we've done in other pieces of work that I've been involved in is that you then map outwards from there and you start to map where that responsibility sits and put in the work that actually needs to be done across everything from information governance to technical capability to workforce. There's all sorts of components of that need to be put in place to enable that transition. And that's very much the ethos behind the Neighbourhood Vanguards. So very specifically, so I sit on the Digital and Data National Neighbourhood Steering Group with Emma. And one of the clear kind of components of the way the Neighbourhood Vanguard programme is set up is that those vanguards must have buy-in from all of those providers. So all of those potential people that you're talking about, Carl, not just the GPs, but everybody within that system who owns some component of the data, let's say, they have to be involved in coming together. And that transdisciplinary approach is fundamental to the way the vanguards are supposed to operate, because these are thorny issues. Multiple initiatives have fallen down exactly on that issue. I saw Basil Bekdash had a lovely quote in one of the recent Digital Health Network articles exactly around this, and I 100% agree with him. This is part of the hard work that has to be done as part of these initial vanguards to tease out what that actually means and not get caught up in, as we nearly always have done, in our siloed organisational views where it's not about us as organisations, it's about the person and having their lives as the organising principle around how neighbourhood should be set up.
Julia, makes complete sense. We talk about MDTs across healthcare, but actually what we're talking about here is multi-professional patient care. And what that looks like. And one of the things, an area which is missing from this panel is the voluntary sector or charity sector or third sector, which are fundamental in a lot of these local provision of services. I'm just going to give a quote, and we can argue about the figures or not, but in the guidelines, it mentions that 7% of a local population might have 46% impact on local hospital services, and there should be priority placed on the neighbourhoods model on that area first. How does that sit with what Leah's just mentioned, Emma, and how do we work through this process of priorities?
Thanks, Carl. I think the agenda overall for Neighbourhood and how we connect up services, both for the multi-professionals that are involved and also the patient, is complex. We are obviously considering how we can bring the voluntary and charitable sector into that process, particularly at the point of diagnostics, but sort of come back to the need for us to be really clear, but also work with systems to define the problem statements and I suppose the areas that nationally we can support that will deliver that improved understanding and flow of medicines, the role of EPS that we need to be rolling out, considering how we're going to use our referrals management, the ability to track with and better use of advice and guidance, considering how we're going to actually bring a consistent view of appointments and referrals together for both the profession and for the patients and their carers. So I think there are a number of different ways in which we need to approach that, working with the systems directly.
Thank you, Emma. John, could I come to you? And I think one of the things I'd like to just tease out from you a little bit, because you have done some work on this already. What have been some of the main issues and barriers to some of the enablement here? And how have you gone about trying to resolve some of those?
Yeah, okay. So we have been asked to do some things for the first time. Okay, so even sharing a care plan between health and social care is difficult whilst maintaining a single point of truth. So, you know, we found going into this piece of work originally, we found teams who were sharing care plans and information over NHS mail to trusted government accounts because that was the only mechanism that they had available to them. Now that's clearly unacceptable going forward. It does not in any way, shape or form come under the category of doing digital differently. So we've had to try and find a way of using the collaborative tools that we have and making sure that we can share a single point of truth securely across our partners. Still work ongoing. In some areas where you've got, for example, a high percentage of providers using the same system, so you're having to deal with the 20% rather than the 80% of data sharing, that's okay. But when you start to get a real diverse system, and we're still trying to get our heads around the voluntary sector as well, because they all use lots of different systems. How do you get them securely? And as a very early tactical solution, sponsoring NHS mail accounts for trusted workers across various organisations is kind of one way. Again, that's not doing digital differently. We need to start to understand how we can bring a single shared data set amongst lots of shared providers. And it could be things like share care records need to move more into care planning to be able to start to unlock and enable some of that. The other partner who we really need to start giving a lot of attention to in terms of neighbourhoods and care generally is the person themselves. So it's very clear that going forward, patients are going to be empowered to be an equal partner in their own healthcare. Now, again, that's something that we're going to have to get our heads around. One of the early questions was around, GPs tend to be custodians of data. And there are legal reasons why that's the case. But we need to start to get our heads around, actually, how do we empower that trust in patients to be able to manage that themselves without any potential IG or patient access issues? Some of this information belongs to the patients and other people are just custodians of it. And again, that's something that looking at the ambitions of the NHS app, we've got to get our heads around that really quickly. So that's another piece of work that we're starting to pick up now, Carl, is how we can bring the patients more involved. So it's doing a lot of things for the first time, and I'm really hoping that the pilots that are underway will help inform the country generally, because we don't all want to be addressing these problems for the first time.
John, makes a lot of sense. We have had webinars on the single patient record and the NHS app, and one of the suggestions there is they're trying to gather more information from across the local services and what provisions there are for patients to have greater knowledge. But I just wonder how that works for clinicians, Leah. So one of the problems at a local area, whether it's a local diagnostic centre, whether it's a drop-in centre, whether it's a multi-provision health centre, is what's actually available, who can I contact, what should I do next? And that often slows the process. How do you envision that being worked through from a clinical and a data point of view rather than digital?
It comes back very much to what I was saying before about understanding the function of what you're doing. So take my own neuropsychiatry clinic in South London. What we do is I work with a neurologist. So these are neurology doctors, consultant nurse specialists, psychologists, whole team of people who work in neurological services. And we use a number of different types of digital enabler, including the London Care Record, but also a whole load of other things as well. And we use that to facilitate a conversation. And that, I think, is key to understanding how you work through this. And I've done this in lots of times in lots of different types of service. It's being clear that the care, say, for example, the care plan itself, that is not doing the work. What is doing the work is how that relationship works between all of those care providers and the patient and the person. And we know from our psychological work across long-term conditions, the evidence from health psychology talked about patient empowerment. We know the evidence base tells us that when you organize that conversation in a particular way, which means you have to think really carefully about how you're designing your digital enablers. There you go. You knew I was going to say design at some point, Carl. When you think about that carefully, you have the most opportunity to actually increase patient agency. And I'm not using that as a general term. I'm using that as a psychologically evidence-based validated term. And there are very specific things that you have to do to increase that agency for somebody. And what is crucial is how that conversation operates. It doesn't operate on its own. It's within the context of an existing relationship. So to give you a really tangible example, in diabetes, we know that if you just give somebody a choice of blood sugar monitors, you may get some improvements in their blood sugar control, but nowhere near as much as if you operate what we call a logic of care, which is as opposed to a logic of choice. And that means understanding how the care model is operating. When you talked about people access to diagnostics across different sources, it's understanding how do those things need to integrate, and what is going to change either a behavior for the patient or actually a behavior for the clinician. So an example I was given, a question I was asked actually back in NHSX days was something around ordering too many MRI. I'm a neuropsychiatrist, so MRI brain, for example. And somebody asked me, designer asked me, what would stop you ordering an MRI when there's already something? And I said, well, there's a bunch of factors, actually. So it isn't just the fact that the MRI has been done, but I need to know the size of the magnet, the strength of the magnet, because that tells me about the level of detail they might have been able to see on those particular structures. Or I need to know if that report I'm seeing, has that been reported by a general radiologist, or has that been reported by a radiologist who has specific neuroradiology expertise? And what the person who asked me the question said was, okay, Leah, you're talking about design for trust. So when you are thinking about what does that connectivity across those different partners, those different people within that system, right down to how results are shared, etc., it's understanding for me those design principles and what that pragmatically means for actually your service design and functional and non-functional requirements on products.
Yeah. So coming to you, Emma, how is the centre envisioning support and guidance to make sure that the efforts that are being put in locally by support staff, clinicians, and the wider kind of health professionals are actually making hay on what some of the guidelines are currently saying?
Thanks, Carl. I think the centre needs to have its listening ears on, because ultimately we're working with the vanguards, we're working with the neighbourhood health improvement sites to better understand what these needs are. Because John mentioned, much of the join up that we need to do is novel, and we can't pretend that in the centre we have all the answers. Many of the answers have been solved locally in regions who've done the excellent and hard yards of work to actually join up a lot of the social care and health and information that's needed to allow the professions to interoperate. We have to learn from those systems to figure out what nationally our role is to do, and be really specific about that. So I think the work that we'll be doing over the period of the next spending review will firstly be about figuring out what our specific role is without charging in like a bull in a china shop. I think that would be, well, we don't have the money for that kind of mistake, nor do we have the time. So we need to listen, I think, very carefully to the system and unpack what the problem areas are and where we nationally can reduce cost, reduce burden, do things once that genuinely makes the difference. I would also like to talk a little bit about the NHS app, because Leah, as you've mentioned, working with clinical teams around what care pathways may look like in the future is also part of our brief, and we think about the empowered patient and the opportunity that digital data and technology can afford. And part of the work that I'm looking at now is figuring out what some of that might look like linked to changes in care pathways. And we will step our way very carefully into this by thinking about what digital by default means, linked to the increasing pipeline of digital therapeutics and medical technology coming through from NICE, MHRA and other areas. But again, working hand in hand with clinical leaders here and the system who are actually working with patients in real time to understand how those new tools and opportunities can best be worked through, and the role of National to support them. So we've got a big job to do for the patient, who ultimately wants a single view of their health and care. They don't mind which silo it rests in, and we have to be able to remove those barriers for the patients to present coherence in a way we've never managed before at a national level. And again, we'll be taking learnings from systems who've already walked that walk on how best to do that, where the value is.
Emma. John, I'm conscious you're going to have to leave us shortly, but just on that question again on barriers there, and just to give a quick surface view on it, adult childcare is done in a different care system with different software. You've got different coding and different methodologies between acute and GP and mental health. Dare I mention SNOMED or NHS numbers, single identifiers. Then we've got the voluntary sector who don't have necessarily the same kind of care type records. Are those barriers, or are they just things that we need to get through? And what else is causing issues in terms of potential data sharing in the future of what a successful neighbourhood might look like in terms of digital transition?
Yeah, so they are barriers, and it would be 100% easier if we were starting with a blank piece of paper. but we're not. We've all got a starting point. It's all a different starting point, and we need to find a way of making that work. Now, one of the challenges we're going to have to get our heads around and just deal with, and perhaps just get over, is that none of our ducks are lining up. Okay, so if you look at neighbourhood working, if you look at frontline capability, frontline digitization, frontline optimization, 50% of the funding for that is going outside of acutes. Okay, how do we deal with that work stream? Because that's a separate work stream, but clearly there needs to be something overlapped there. We've got the NHS app work stream, which we need to make sure integrates across all of the above. And do you know how many times single patient record is actually mentioned in the medium-term planning framework? 0. So actually, we need to get our heads around, if we're not expecting a single patient record to at least 28, 29, which is when our planning guidance is for, how do we fill that gap? Okay, share care records are mentioned. How do we then plan a transition from whatever share care records are to whatever single patient record are? Okay, very difficult to get all our ducks aligned. We've got very limited resource, organization change going on at every level. We're just going to have to find a way of getting over those barriers, working smarter, working more collaboratively, trusting our partners to lead a piece of work, even if they wear a different lanyard to us. Because actually, if we all worked as one team rather than 15 different organizations, and we start to rationalize our workflow a bit, we might start creating a bit of capacity. So we've got to just recognize a lot of ducks to line up, a lot of capacity to find and from somewhere, and then a lot of trust needs to be generated across the systems. If we do that, Carl, and actually some of those barriers that you mentioned, which are real barriers, but we can start to get round some of those.
John, super helpful, and thanks again for joining us, and good luck this afternoon. As John mentioned, he is the chair of our ICS Council, one of our networks. So if you do want to continue the conversation, ask John some questions, please do go on to Discourse and continue the conversation there, and we'll always bring it back to the centre in future webinars. But for now, thank you very much, John. A pleasure as always. So Emma, again, looking at multidisciplinary teams, multi-professional care, there is a suggestion that obviously it's done in the local region, which is very kind of GP focused, modern GP services. We mentioned the single patient record in the app. We've got allied health professionals, local health professionals, mental health, local government, etc. There is a suggestion that acutes would get involved when it comes to particular care, whether that is issues with long-term conditions that could be treated at home, whether that is for virtual wards or doing clinics locally. With the funding model, which was briefly mentioned earlier, how do you incentivize trust medical professionals to actually get out of the hospital and go to a local hub and actually change the way that we're doing things at the moment?
Thanks, Carl. Probably want to bring Leah in on that question also. I mean, I would say that, again, this type of working is happening already in places up and down the country. And again, the we're waiting for the model neighbourhood to give us some clarity on what the assumptions are that nationally we're looking to drive through neighbourhood, and I suppose what the immediate changes we might be asking systems to make. But again, I come back to the point that we must learn from the models where these things are in place, and that is work that the Neighbourhood Health Improvement Programme will be bringing together with those 43 areas. Because, you know, when I talk to clinicians that I've been fortunate enough to speak to recently, there's obviously a real willingness and an appetite, and already a practical route for those things happening as they stand at the moment. I think what isn't clear yet is how all the funding flows and the incentives will work, not just between specialists that are working in the acute seg, but also how we're looking at the capacity and demand management between GPs, between community pharmacies, between optometrists. I think there are a whole range of considerations on how those flows need to interoperate amongst those various sectors, and we don't have all the answers yet.
Thank you. I mean, I think not having all the answers is fine. I think one of the key things here is understanding that there are issues, and whether it's tariffs, whether it's QIP or other priorities, there does get to a point where it says, okay, yes, it all makes sense for us to work together, but actually I'm not going to, because where does the money go? And I'm going to spend my time doing that, and no money will come back into my hospital. So why would we? And chief exec, chief operating officer under pressure in debt is probably not going to be quite as flexible as some of that kind of wider aspiration. So as you mentioned, Leah, how do we get around doing this? Because we can't just, it's not just a room full of the willing. There are issues here that we need to deal with.
Well, that is one of the reasons I am more positive about the Neighbourhood programme for holistic care than I have been about lots of the other initiatives that I've worked under, because there seems to be a proper commitment to actually transforming the major areas that will contribute to this model transformation. So digital and data is one steering group, but funding flows, workforce, estates are the other three. And I can see Richard's put a question which is literally around this in the chat. And I think that is the answer. There is a very explicit commitment that what comes out of the Vanguard programs will set the pattern for actually how this continues to move forward. And I already know, so I work, my clinical work is in Croydon, and Croydon is one of the Vanguards. And I know that in that area, we are lucky, and what is one of the reasons that I think Croydon got Vanguard status, was because the partners are really forward thinking. So the chief exec of the local acute is totally engaged with this. I have had really interesting conversations with those clinicians who totally recognise what the challenge is. Some of them are already working in the community and community models. Others of them know that they need to. So, traditionally, the geriatricians, the care of the elderly doctors, they already get this. They already do community models. We've been working with them in day hospitals for forever now. But actually, I'm also hearing it from the cardiologists who are heart failure specialists, that they recognise this is where the future of care is, because we can't do anything else. It's very much part of that Darcy review, the three components. And this is very much in contrast to where we were a decade ago, when I was building models under the Better Care Fund and would have extremely difficult conversations with, for example, respiratory doctors, I won't say where there was an attitude of I'm not stepping out of the hospital. But I think we are in a different ballpark now. There is willingness and a recognition that we can't continue doing the same, plus that commitment to funding models will change. Workforce organisation will change, and it will be guided by what of the Vanguards.
Thank you, Leah. Emma, I know you can't have a solid answer on some of these things because you're still working things out, and I fully understand that. But there are the willing, as Leah mentioned, and as I mentioned previously. There's also the people who like to hang on to power. There's the people who don't have the physical capacity to change or do things differently or know what to do. Some ICSs are stronger than others. Some have been working on this longer than others. There is a disparity between the quality of shared care records, which is some of the underpinning work of the single patient record. So how do we get this as a kind of system-wide service which makes sense for people, where care is delivered in a similar way at local behaviours?
Well, I was just going to reflect there on, I suppose, the the advances that we've seen, and I suppose, if I may use the word success of the NHS app as an organisational construct and principle, which looks at patient first. And when I started working NHSX as it was 5 years ago, I think we had 500,000 users, and now we're up at 34 million registered users and 14 million of them there every month. And at the beginning of that journey, there was an aspiration for consolidated services for citizens, but there was very little under the bonnet and very little usage. And I suppose I'm just thinking about the need for Neighbourhood, not only to consider the journey that the system needs to go on to join up the many disparate and fragmented components of it together for connected working, but also for the ability for the patient to manage that health and care journey consistently in one place, which again is what people are saying they would like to do. And I suppose I take inspiration from the fact that we have had a great deal of success now in considering how we can join up elective and primary care for the citizen into something that is coherent for the services to manage and for patients to manage. And I take for me, I'm considering how we take a lot of the learnings of the work under the bonnet to achieve that and think about how we can transpose that to support parts of our health and care system that haven't had that lens, haven't had that focus, haven't had that priority and that enthusiasm coming together, as Leah has mentioned, to solve some of these problems at a national scale once, with a view to figuring out what that means for the person and the individual. So I hope that gives you an answer to that question.
Yeah, I'm just going to push a little bit more. So we've, because obviously there are examples, and we can take these. Now we've had global digital exemplars in acute. We've had blueprinting initiatives. We've had other pilots. One of the things that, from my time in healthcare, is I often see these things not get scaled up at a national basis, or even if things are written in the blueprints, there isn't that drive into copying those, following those, and then what that looks like. Shared care records is quite hard work. There isn't the financial or funding incentive to necessarily do it. So it is sporadic in terms of how well they've been implemented and the drive of local providers in that sense. How do we try and change that in that detail? And I'm trying to avoid saying, how do you mandate this, Emma? But that's basically a bit of what I'm trying to get to.
No, I understand, Carl. And I suppose I'll take some examples of where we have started but not completed things. So if we think about investment that we've made in coherence of referrals, thinking about the electronic referral system, it's not yet integrated in all organisations. We think about electronic prescribing and the critical nature there is across all services to have a clear view of meds, the ability to flow prescriptions and medicine views across the system. Again, we haven't in fullness managed that. We hear time and time again from clinicians the risk and the challenge they're put under in very time pressing situations of not having those things resolved. I think we've got to look at funding. We've got work in the medium-term plan, haven't we, which says we must move in these directions. We must consider our national platforms as to drive the coherence around some of those things. And again, going back to picking the important parts of our service that need the join up, won't be everything, but it's definitely components of it that are needed for patients to be able to flow around a complex system. And we will have to incentivise that. And we know that we've got business cases that are going in nationally looking across the needs of health and care systems. It's a very challenging time for revenue. I think everyone's aware of that. But if we don't address these things from a funding point of view, enabling providers and the services to do the work that's needed, then we will remain challenged. So what I would like to see is coherence across the funding that's being presented in the business cases that we've got for SR, so that those working out in the system on the nearer the front line and on the front line are really clear how they're going to be supported to make these changes.
I think it makes complete sense. I mean, it's all well and good saying that there's no more money, but we all know that acute sits with just over 70% of that funding. They've had a big increase in doctors and clinicians, since 2010, whereas primary care practice is shrinking. So there is a bit of a disconnect here, one in terms of funding and also in terms of that resource which is there. So if you just look at where that is, Leah, what needs to change in terms of that balance and where some of that focus is in order for us to be achieving some of the ideal goals from neighbourhood working?
So I think one of the key opportunities really is starting to think about our digital services in the same way that we think about clinical services. So one of the things that I've seen, and we were talking about it at the Shared Care Record Summit, for example, is when we think about digital services, we tend to talk about utilisation, numbers of active users, this kind of stuff. And we know how to commission clinical services. We will talk about activity, but we will also try to focus on health outcomes and also the impacts on system KPIs. I think we have to bring those two things together. And one of the kind of difficulties of that is not so much about the digital piece, it's actually about the complexity of these services. So liaison psychiatry, my professional area, is an area in which you might be working for one organisation and putting in an intervention somewhere else, and then the impact might be seen somewhere else in the system. So the approach that they took a few years ago now to funding the national business case for liaison psychiatry was very much putting in place a model where we were looking at outcomes across all of these constituent parts, a balanced scorecard approach. I would like to see a lot more of that around digital clinical services. So matching up that way we think about clinical services and that way we think about digital services and putting that together so we can really see where the money is, we can see where the outcomes are, and we can actually track that. And that will help us understand where we need to shift funding to, where more work needs to be put in to actually produce that outcome, those outcomes that we're looking for.
Thank you, Emma. And just continue on the same line, I just wondered, Emma, in terms of some of the key work streams and priorities that you're working on in this kind of near future, and when I mean near future, I mean in a few years, not next month, where do you see some of this change and support and extra kind of guidance being given in order to achieve some of this?
So some of the things we're thinking about, you've touched on single patient record, and I think, as you said, how many mentions are in the medium-term plan. We're thinking really pragmatically about this, and we'll be working with systems to figure out how we can build out an improved picture of what we've got today. So we've got a lot of foundations in place that already help join up information and flows for the service. And we need to consider both how we can expand access to those and increase their utility. And for example, things we're actively working on now, I'll take an example from optometry. So optometry currently use the NHS.mail to flow their referrals and conversations back and forth between the various different parts of our forest. We need to bring that more into shape in line with allowing single points of access to look at triage for systems to be able to manage their demand appropriately. And where we have been doing that in some of the pilot areas, we're seeing quarter of the referrals or that might have gone into the elective care waiting list not being required, and we're seeing triage times cut by 10 days into one. So we know that where we can start to apply these models, they are helpful, but they require, again, us to be able to support parts of our health and care system to access our national system. So we are providing access into electronic referrals for all of high street optometry. That's a commitment we're aiming to get to 70% by the end of March 27. We'll do that initially through some simple web access. We may well look at how we can build access into NCRS as part of that, some of the basic care record, to really give optometrists in the high street a far better understanding of who's in front of them and their needs, and also a way of referring that through into the system. So taking that as an example, I think we have foundations that we can start to build on and think about the use cases that will improve the health and care, help the support needed for the various professions across the health and care service. There is no magic wand to an SPR that's going to appear in the medium-term framework timing. We know that from the guidance, we probably know that from practicality, but there is definitely foundations that we can build on to improve the picture, and it's those types of opportunities we'll be looking to draw through.
And I guess one of the questions which has come up just on basic systems as soon as you add multidisciplinary care in there is read and write access versus just read access, where that is, what access there is for that patient, how that's managed by the clinician or not in terms of choice. And also being able to share access to maybe your designated carer, which you can do on the NHS app at the moment. But some of those principles, you would assume would assembly on from that. But in terms of actually being able to deliver that care and where that point is, does it rest with the GP, or is it a neighbourhood decision? Where's the change in that area going to come? I'll let Emma or Leah. I'll try and answer that one.
I'll allow the clinician to take that one first.
Oh, pop out, Emma.
I think it comes from, I don't know if that's the right distinction, to be honest, because it's all about where somebody is in their particular care journey. And sometimes it might be the GP, but sometimes it might be it might be the psychiatrist in the clinic, or sometimes it's always going to be the patient, right? It's always going to be the patient. So I would start there, and then it is feeding out from how does that operate round it. And that's that real piece of trying to move from a very paternalistic structure to one where the person is actually properly at the center of it. And we're not great at doing that. So that takes some really, really hard work, and you have to know that is what you're doing. And there are good reasons why we're not good at doing that, because we have a professional job to do, and we hold responsibility, and so there are certain things that you've got to understand that's what's going on. So when John was talking earlier about empowering the patient more, and that sort of how we can have two-way access, that's great. There are loads of amazing things that we can do with that, but it's also understanding where some of the red lines are. So for example, blood pressures. It's really important to know what device a blood pressure was taken on and how it was taken, and all sorts of bits of metadata. Otherwise you can't make a clinical decision around that data point, and it is unsafe for the patient. So we've had this in the blood pressure program. It's like, why can't patients upload this? It's like, well, because if that becomes a source of truth and you have these clinical safety risks around that, that's really serious. That means I can't discharge my job of actually treating this person's condition because we haven't fully understood what the job here is. And I think that is, again, going to be a really important piece for neighbourhood models to understand, is that it's this collective endeavour, but we must understand how digital needs to be designed responsibly and safely to ensure that the right outcome is there. It's about people's needs, health need.
Thank you. So that starts to touch on governance, data ownership, correctness, accuracy. So Emma, coming back to you in terms of that from the centre, obviously there is different legal legislation depending on whether you work for the NHS or whether you work for a local authority or a wider kind of voluntary sector. What's the centre doing to look at that in terms of removing some of those barriers of where legalities, responsibility and data ownership is? And I'm not talking about the patient record here, I am talking about data.
It's a complex world, Carl. And I must confess, I don't have a detailed answer for you on it, so I'm not going to claim that I do. Suffice to say, I think particularly if you think about it from the NHS app, we're very careful about what we're doing around the ability to link data on behalf of the individual and the different data sets together. So there is quite a lot of work going on there around the legal direction that allows us to join up health and care services for people, particularly where we're thinking about increased personalisation. So, for example, ideally, when someone contacted us through 111 through the NHS app, they've been through a login, we know who they are, we ought to be able to identify whether they're a red category risk or someone on a green category risk, and actually adapt the pathway that's offered to them at that stage. So we're looking at those types of problems on behalf of the citizen experience and what needs to be joined together to support it. But similarly, there is an awful lot of work going on, again, connected to the Neighbourhood Health Improvement Programme and the broader needs around how National can better support the data agreements that need to be made between the various different parts of the system. And we know that there's an enormous burden on local teams who've already done, in many cases, or in some cases, the hard yards to do all the DPIAs and it's the 251s, isn't it? Apologies if I've got the numbers wrong, between the various different parts of the system. And nationally, we need to take different positions of that based on the legal position that we're intending to improve over the next couple of years.
Yeah, no, I know it's a difficult question, not necessarily your remit, so I fully understand. I think one of the problems that we've looked at in the past is around trust, and there has been quite a lot of trust with the NHS. There's been trust with GPs, there's been trust with local authorities. We trust them to process our council tax. We trust the local authority to educate our children. We trust our local GP to meet us and book us for appointments. But when you look at this on a neighbourhood side, with care.data and issues there, with issues raised around Palantir, with issues raised around whether the access is being shared with other organisations. There was an instance with Google in London in particular. How do we make sure that trust is there when we don't have data which the patient is allowing access? It wants to be held by the centre, and then you decide where the access is. Whereas if I was the patient and I'm deciding that I want to give you access in order for my treatment or my service, it then becomes a different paradigm issue. But in terms of where we've been and some of those kind of trust models, how do we deal with that with patients, that patients want to engage with this new neighbourhood model and feel like it is trusted? Emma, I'm going to have to come to you on that one, I'm afraid. You're on mute, Emma. Sorry, I know you're thinking, but Emma, you're on mute. Sorry, I was coming to you on that one. Yeah. There we are. Hello? We can't hear you. Leah, would you mind coming? I've lost Emma's sound.
Sure. Can you hear me?
Yeah, I can hear you fine, Leah. Sorry, Emma, I've lost your sound. Go on. I'll pass the hospital pass to you instead then, Leah.
Well, from my perspective, trust is hugely important. And once you lose that, you lose what's fundamental to the basis of your therapeutic relationship. So I think that it's something really important that the centre has to really consider in how this operates. A lot of what we do in existing shared care models at the moment is fundamentally predicated on this relationship between the patient and the professional, and the kind of nuance of that I think the kind of digital components have to really kind of carefully facilitate. It is things like surfacing where there might be something that the patient just won't know is an issue. So I'll give you a not too specific, because I want to be identifiable, but a kind of amalgamated story from my own clinic. So what often happens to patients that come into our pathways, they have been on a very medicalized route. They're people who have seizures, and the underpinning of those seizures can be very physical, or it can be something psychological. Quite a lot of people maybe have had experience of childhood abuse, trauma, or maybe currently experiencing that. And so we've had situations in which one of the key intervention has been recognizing a pattern in how somebody is presenting, for example, presenting at A&E with seizures between 11 and 12 at night, which strongly indicate from our experience that there's the potential that somebody's experienced domestic violence, because that is pub closing time. And the intervention that you need to put in place for that is actually multi-agency working, and being able to access sensitive data, or encouraging people that some of this sensitive issues must be explored appropriately when that person. So this is again that transition from a medicalized model to this biopsychosocial model. Now, when you're thinking about how your digital enablers operate on that, that's an absolute shitload of really sensitive data, and knowing who's going to be able to make the right insight out of that is very difficult to predict. And this is where I've certainly had this experience developing these services frontline. There was a period in Surrey, for example, a few years ago, where the information governance, I was employed by the Mental Health Trust. I was seconded to Virgin, who were actually running the primary community care at the time, delivering my intervention, sometimes in primary care, sometimes in secondary care, and the impact actually being seen somewhere else entirely. So proper cross-organisational working. I had to walk around with a letter that somebody got me from Dame Fiona Caldecott saying, please give Dr. Ali access to this patient's notes, because all of those individual organisations were protecting their own responsibilities, but not knowing that they in order to actually get the right outcome for this group of patients that we were looking at, you needed to enable someone trusted, trustful, I'm pretty trusted most of the time, that it was okay for me to see that, because that allowed me to make those decisions and to help other teams, multidisciplinary teams, to understand what was going on, exactly like we do in our neuropsychiatry clinic now. That's really tricky from a central level to know where the right place is to actually to put that lever. But you know, it is possible that what they needed was a sign off to say, and literally it was one from Fiona Caldecott to say it's okay. And that for me is a really important role of the centre, to be able to give some guidance so that organisations know that it's okay to start to move towards this, and to also help put the guardrails in place to be able to facilitate that learning, because it isn't black and white. We've had incidents where, you know, sensitive data has been seen by somebody who doesn't really need to access that. That's why role-based access work is so important. And it's really getting into the weeds of that of transformational change, and then being able to step back out and understand how the centre supports that through those digital enablers.
Julia, Emma, are you back with us on sound?
Testing. I hope you can hear me now. Thanks, Leah. And I was just going to say, following that, thinking about it from the clinician side, I'm also thinking about it from the patient side specifically. And we think, well, what does trust actually mean in the context? There's obviously safety and security of their own data, but there is also about consistency, familiarity, people feeling that they're known and understood, and our ability to demonstrate that so that people aren't repeating their story, they know where they are in their journey. And again, I think about the opportunity that we have through the NHS app to bring that consistent view and that ability to feel known for people as an experience of health and care. And we probably don't really have anywhere else where we could do that. You know, it is the one national channel where I think we have a responsibility, and in fact have been tasked through the 10-year plan to drive that coherence for people. And I think the more people can recognise, for example, their messages coming from a known entity through the NHS app, people feel that's more trusted than an SMS from something that they don't recognise with initials or acronyms that aren't familiar or don't say NHS. The more we can start to build on an intuitive engagement and an experience that's presented to people that demonstrates that we understand who they are and what they care about and what their needs are, the more we can drive and build trust connected to how we want to run our services in the future.
Thank you, Emma. We are coming towards the end, so Leah, could I just come to you for any final key points that you want to raise, or just an emphasis on anything?
I think it's just back to the piece that I was saying, that this is about a model shift. So it's not about buildings, it's not about, you know, a particular bit of digital technology. It is about a model shift, and the opportunity is huge there for me. And that means thinking about, from a digital perspective, is thinking about that full landscape of capability we have now and what we could have in the future, and understanding how it allows us to do that transition, and keeping that really in mind, and doing that connection up between clinical services and digital services.
Same for you, Emma, please.
Yeah, no, thanks. I mean, I can build on that, Leah. I think for me, I just think, actually, how does digital over the next period actually work as part of our envisioning of what comes next? I don't see digital as a component on the side. I think it's fully integrated in enabling what neighbourhood teams will need to do. And as I said, I think there's a journey to go on to learn from systems that have done hard yards locally to figure out specifically where national needs to invest its time and effort to best support people working in those professions on the ground. And I said, I'm genuinely really excited, I think, about the opportunity and the enthusiasm around this agenda to make a difference in the areas that have been underinvested and perhaps under-supported for some time.
Yeah, and I think it's a very solid point to finish on. I chaired a session at our summer schools recently, and everybody in the room was very positive about the principle of neighbourhoods and community care and the direction. So I think there is a group of the willing. I think, as you rightly mentioned there, Emma, there is a bit of highlighting of what works and what doesn't work, and some stronger views and support from the centre to push through some of those. But there is going to be trust, there is going to be access issues which need to be fundamentally acknowledged as we move along this in order for patients to get the benefit that they are. But really pleased that people are focusing on this. Thank you very much for your time. Thank you, everybody, for joining us. I will see you all again soon. Take care, everyone. Bye-bye.
Thank you.
Okay, the